Good afternoon, everyone. We will discuss today an important topic, which is how to perform a focused bedside echo. A basic question: is it important? In every emergency shift, we have this scenario of a 40-year-old gentleman smoker presenting with a 3-hour history of severe chest pain. His first set of troponin is negative. So, is this patient is cardiac and his pain is ischemic, or he might be still cardiac but non-ischemic pain like caused by dissection or embolism or pericarditis, or it might be non-cardiac at all. Another scenario: 60-year-old lady with a big history of ischemic heart disease. She has a diabetic foot and presenting to ER with shock. This is a real situation where, as a cardiologist, assuming this shock is definitely a septic shock, while stumping the patient with a stump of cardiac history, giving the patient a straight diagnosis with cardiogenic shock from the internal medicine point of view. Another scenario: 35-year-old lady presenting with shortness of breath and chest pain. Her examination is free, so you might thought this patient might be have psychological trouble or something like that, but you will find this patient return again after 2 hours shocked. So echo is important in every scenario of these, and we will discuss this later on. So this echo is fortunately you don't need these equations for echo. We have this important figure that we will discuss repeatedly all over this lecture. We have 3 positions where we put this probe or the echo probe. This echo probe has a marker, and according to the direction of this marker we get this picture. When we put this probe at this position, which is in the third left parasternal space, with this knob directed towards the right shoulder of the patient, we will get this view, what is called parasternal long axis view. Simply interpreting this picture, we have a left atrium, mitral valve, left ventricle, aortic valve and aorta, and this is the right ventricle. Remaining in the same position while rotating the knob of this probe towards the patient's left shoulder, we have a cut section on the left ventricle, and imagine if as if you looking at the ventricle from the leg side of the patient, and here is the left ventricle cut section, here is the septum, here is the anterior wall, lateral wall, infralateral wall and inferior wall. Moving towards the apex of the patient with the knob of the probe directed towards 3 o'clock or laterally, we will get this classic what is called apical 4-chamber view, where we have the left atrium, mitral valve, left ventricle, and on this side we have right atrium, tricuspid valve and right ventricle. Slight tilting of the probe a little bit cranially, we will get the aorta at this side, and this will be called apical 5-chamber view. The next position will be in the subcostal area with the knob of the probe directed laterally at 3 o'clock. You will get a view similar to the apical 4-chamber view with the liver seen on the left side. When we turn the probe towards 12 o'clock or vertical, we will get the inferior vena cava. So simply we will start with putting the probe at the left parasternal space, at the third parasternal space, with the knob directed toward the right shoulder. We get parasternal axis view. Rotating clockwise toward the left shoulder, we will get the cut section. According to the tilting of the probe, we might cut the left ventricle at the apex or at the mid segment, as shown here at the level of papillary muscle. Tilting more upward, we will get a cut at the level of the great vessel. What shown here is at the level of the papillary muscle or mid ventricular level. Moving to the next stop at the apex, with the probe looking laterally, we get the apical four-chamber view, and finally at subcostal to get a similar view to the apical four, which is called subcostal view, and anti-clockwise rotation toward this 12 o'clock will get this view of the inferior vena cava. We will go through this cycle in every scenario of the coming scenario. So you should be familiar with the echo machine available at your department. Here is the Philips machine. When you put the probe and get this picture, this is called 2D view. If you want to get a cut section at certain area, this is called M mode. If you want to measure pressure gradient across a valve, you will use this button, which is called continuous wave Doppler button. If you want to measure pressure at a specific point, this is called the pulsed wave Doppler. If you want to assess regurg or flow across a valve, you will use this button, which is color Doppler button. If you want to adjust the contrast of the picture or the gain, you will use the gain button, and this button acquired for saving your picture, and measure button for direct measurement, calculation button for specific measurements. So we will go through two clinical scenarios. The first scenario is a chest pain plus minus shortness of breath present. We have four important differential diagnoses for this combination. First might be myocardial infarction. We have definitely clues from the clinical picture of the patient, the nature of the pain, the ECG, the lab like troponin, but we might still be not quite sure about the diagnosis. And here is the role of echo. Second possibility is pulmonary embolism. Also, it has specific clinical features. We have some clue from ECG, EPG, and X-ray. We have Wells clinical criteria, and accordingly, if it's low, we'll go for D-dimer. If it is high, we will go straight forward for CT pulmonary angio. But still, we can get some clues from echo to help us in the diagnosis. Third important possibility, a fatal problem, which is aortic dissection. So we might have clue similarly from clinical picture, from wide mediastinum at X-ray, and definite diagnosis by CT aortography. And then we might have clue with echo. And then pericarditis, the nature of the pain, the ECG characters might help. Echo can give clue in each of these four important differential diagnoses. In case we see certain area of the myocardium contracting less than the surrounding, we call it regional motional abnormalities, might give us a clue of underlying myocardial ischemia. If we see some signs of the suffering of the right ventricle cause of pulmonary embolus, we might get directed towards a diagnosis of pulmonary embolism. If we see the dissection flap or its secondary effect with our association aortic regurgitation might direct us for dissection. If we have effusion, might direct us also towards this. Starting with the first differential diagnosis, which is myocardial infarction. As we said before, we are assessing the presence of what is called the regional wall motional abnormalities, where the territory of one of the coronary arteries, LAD, circumflex or RCA, contract less in comparison to the surrounding due to the presence of ischemia at that territory. So how echo can help us at this scenario? Starting with the different views that we discussed before. Here at the apical four-chamber view, we have the anterolateral wall, which is supplied by either diagonal or circumflex artery. So if you have regional motion at this wall, it might be caused by either of them. And the apex, which is supplied by LAD, and the posterior septum, which is supplied by the RCA, and partially with also branches from the LAD. If we tilt the probe a little bit anteriorly and we get the aorta, then we are looking at the anterior septum, and the anterior septum is supplied by the LAD. So if we get the aorta A, then we have the A anterior septum. If the aorta is closed, so it is posterior septum. Then we have this view, which is parasternal short axis view. As we discussed before how to get this view, this is an important view where all the territories are represented. We have the anterior septum, which is supplied by LAD, anterior wall, which is supplied by also the LAD, anterolateral wall supplied by circumflex and diagonals, the inferolateral wall supplied by circumflex, and the inferior wall and the posterior septum supplied with the right coronary artery. So a combination of these views, we can get a clue towards the ischemia in one of the coronary territory. For memorization, this wall stands for SALB: septum, anterior, lateral, posterior, and inferior. So if we go classically, as we discussed before, the three positions and the four views, starting with the third space, left parasternal long axis, we get here the septum and the posterior wall, septum supplied by LAD and posterior wall supplied by the circumflex artery. We rotate the probe clockwise towards the left shoulder, and we get the short axis view at the papillary muscle level. We have the septum, anterior wall, lateral wall, posterior wall, and inferior wall. This wall supplied by LAD, this supplied by circumflex, and this wall supplied by RC. Then moving towards the apex, the apical four-chamber view. If the aorta is closed, it is the posterior septum supplied by the BDA branch of RCA, tilting slightly anteriorly and getting the aorta open. At the apical five-chamber view, we'll get the anterior septum supplied by LAD and the apex supplied by LAD also. Lateral wall supplied by the circumflex. Here is an example of what we have discussed. Here is a normal patient. We have septum, apex, lateral wall contracting well, and this patient coming with severe chest pain, and we have, as we appreciate here, the apex and the apical part of the septum hypokinetic or almost akinetic in comparison with the rest of the walls. The same patient, short axis view, all segments contracting well, but but here we can appreciate that also the septum and the anterior wall are almost akinetic. And here is the coronary angiography of this patient. He has proximal LAD significant lesion. Second differential diagnosis is pulmonary embolism. Pulmonary embolism, we have different clues from echo. Simply just putting the probe at the apex and getting the apical four-chamber 2D view, you can appreciate RV dilatation. What mean by RV dilatation? Normally the LV is larger than the RV. If you get this view and found RV equal or even more enlarged than the LV, this means without any measurement that the RV is dilated. And here is the first sign. Very simple. Second sign, the suffering RV from the significant sudden afterload caused by pulmonary embolism cause pressure overload of the RV thin wall that might cause some ischemia on the right ventricular wall. And as we saw before, the ischemia in coronary arteries cause the wall to move less than surrounding, what is called regional motional abnormalities. This sign described by Dr. McConnell at 1996 when he noticed that patient with pulmonary embolism in about almost more than 80% they have regional motional at the RV free wall, where the RV free wall is almost akinetic and the only moving segment is the apex segment of the RV, which is tethered or pulled by the LV apex. This differential movement or this regional motional abnormalities with akinetic lateral wall and only moving apical segments called the McConnell sign, and has a good sensitivity for pulmonary embolism. Third sign is what's called 60-60 signs. Starting with physiological background of what happened, or pathophysiological background of what happened when we have a large pulmonary embolus. It causes, as we told before, significant rise in the afterload of the ventricle. This will lead to low perfusion of the lung. As a compensatory mechanism, the RV tried to create more pressure to overcome this obstruction. But as we told, this happened suddenly, so the RV can create pressure but not so high. This pressure is usually below 60. So if we measure the RV pressure and found that elevated but still below 60, this means it is most probably acute elevation caused by pulmonary embolism in this scenario. How to measure the RV systolic pressure? Simply, you put the color box at the tricuspid valve and then press on the continuous wave Doppler button. You will get this shape which represent the flow across the tricuspid valve, and the direction of the wave represents the direction of the flow, so it is the tricuspid regurg flow. Just put the measurement button at the apex of this wave. You will automatically get the RV systolic pressure. Second part of the sign, the second 60, is the pulmonary artery acceleration time. What is this? Simply, as a short axis view, as we told before, if we tilted the probe a little bit higher, we will get a cut section. Instead of the papillary muscle, we will get a cut section at the great vessel view. And at this view, we have the Mercedes sign of aorta at the middle of the view, tricuspid valve on the left, and the pulmonary on the right. Similarly, if we put a color Doppler at the pulmonary valve, then press on the continuous wave Doppler, you will get the flow across the pulmonary artery. And if you find that the pulmonary artery close early, that means that the pulmonary exhalation time is below 60. This goes with acute pressure overload on the right ventricle. In contrast with chronic situations, the number is higher than 60. So this might be a little bit complicated than the simple RV dilatation sign or Myocardial sign. We get apical 4-chamber view, color, Doppler, in continuous wave Doppler, measures the pressure. If it is below 60, same exercise on the pulmonary, and measure the time, acceleration time from the start of the wave to the peak of the wave. If it is also below 60, it is called 60-60 sign, and it is one of the sign of pulmonary embolism. And here is the Myocardial sign. So back to the algorithm that we move along. The first position, we put the probe at the left parasternal space, the probe directed towards the right shoulder. We get this view. We can catch an RV dilatation also at this view. Then rotating the probe towards the left shoulder and tilting it upward to the great vessel view, putting color over the pulmonary, then pressing on the continuous wave Doppler button. We will get this wave, measure the time from the starting of the wave to the peak of the wave, less than 60. We get one arm of the 60-60 sign, and continue at the apex of the heart. Simply as a 2D view, will appreciate RV dilatation when we saw that the RV is equal or even larger than the LV, and we get the second arm of the 66 sign by the same exercise, putting color Doppler over the tricuspid valve and press the continuous wave Doppler button and measuring the peak of this wave, and we will get the RV systolic pressure. If it is below 60, now we have the 60-60 sign accomplished. If we put the probe subcostally and direct it towards 12 o'clock, and we get the inferior vena cava. In case of rise of the RV pressure, we might get a dilated inferior vena cava also. Third scenario is a simpler one, which is aortic dissection. Just putting the probe in the parasternal space, but a little bit higher level, might be the second space, with the node directed towards the left shoulder, getting the parasternal long axis view. But when getting higher on the second space, we get the aorta on the center of the view, and we might get the measurement of the aortic root. Measurement of aortic root is done at the end of the diastole while the valve is closed. Here is the sinus of valsalva, here is the sinotubular junction, and here is the aortic root. This might be important for surgical purpose. And there is an example of aortic dissection. Last scenario is pericarditis, a patient coming with pain, most probably pericarditis. Putting the probe just anywhere you can get this equiescent shadow of pericardial effusion. When we measure pericardial effusion, we measure it at the end diastole, while the ventricle is at its maximum diameter and the effusion in the least diameter. This is the safety point of view, because when we are at the cath lab doing aspiration for the effusion, and if we measure at the systole, where the effusion at the maximum diameter, we might get over estimation of the effusion, and perhaps we might get the RV wall injured cause it is too close to our needle. So when we measure effusion, we measure it at the end diastole. As we said before, on assessment of effusion, putting the probe in any of these positions, you can appreciate the effusion. Here is the parasternal long axis view. If there is effusion, you will get it here or here. Short axis view, all through the view, anteriorly or posteriorly, laterally, and here apical four-chamber view on the lateral LV wall or lateral RV wall, and then important view on guidance of subcostal drainage of effusion is the subcostal view. We get equilucent space between the heart and the liver border. And so back to our first slide. Now if we have this scenario, chest pain and shortness of breath, and we put the probe at the algorithmic view we discussed before, if we have regional motional abnormalities, then this goes with ischemia. We have the RV dilated and pulmonary pressure elevated or Myocardial sign, we go for pulmonary embolism. If we saw the dissection flap at the parasternal long axis view or aortic regurg, we go for dissection, and effusion with chest pain characteristic of pericarditis, we go for the recurrence. Second scenario is patient with shock. How echo might be in this scenario. If we have a patient with shock, it might be cardiogenic shock, septic or hypovolemic shock, obstructive shock by pulmonary embolism, or by tamponade. As said before, in every scenario of this, we have clinical and laboratory or imaging clues, but also echo might help in this scenario. In case of cardiogenic shock, if we find the patient with markedly declined systolic function, dilated inferior vena cava, which means volume overload, or significant lesion in one of the valves, we might go more with cardiogenic shock. If we find a normal left ventricle and the right ventricle with IV almost collapsed, this go with distributive shock like septic shock or hypovolemic shock. If we get the signs that we discussed before of RV suffering, we go for obstructive clue like caused by pulmonary embolus, and we simply, if we get effusions at compressing the right ventricle at diastole, we go for effusion as a cause. First scenario is cardiogenic shock. Simply how to assess the left ventricular function. At this view, which is the parasternal long axis view, we put the probe in the third space with the node direct towards the patient right shoulder. We get this view: left atrium, mitral valve, left ventricle, aortic valve, and aorta. Here is our right ventricle. When we press on the mode or the cut section button and get aligned with the tip of mitral valve, perpendicular on the septal and posterior wall, we get this view. This view is tracing of this point of interest all through the cardiac cycle. At systole, and this ventricular muscles close to each other, and in diastole when it is maximally dilated. If we have ECG tracing, the end diastole is synchronized with tip of the R wave, and the end systole is synchronized with the end of T wave. Just measure the diameter at the end diastole and end systole, and you will get automatic the patient ejection fraction. Or you even don't need this in the scenario of cardiogenic shock. In case of cardiogenic shock, you will have a severely impaired ventricle most probably. So just by eyeballing, you can appreciate that in this short axis view, this ventricle is have a good LV systolic function, while this ventricle is almost standstill. Same patient at the apical chamber view. Here is good LV systolic function, whilst the previous patient also have the ventricle almost standstill as we said. So just by eyeball, if you have this scenario, mostly this is not cardiogenic shock. It might be distributive shock, septic shock, or something like that. If you saw this ventricle, most probably it is low cardiac output, have an element in this shock. Second assessment in cardiogenic shock is the volume status. This is a simple exercise done by putting the probe at the subcostal view with the knob directed at 12 o'clock facing upward. You will get some tilting to the right, the inferior vena cava. Then you measure the inferior vena cava diameter at 2 times, first at expiration and then at full inspiration. In case you find it markedly dilated above 2.5 and either not collapsing or collapsing but less than 50%, that means that patient is overloaded or congested. On the other hand, if you get a measurement of below 1.5 and fully collapsing with inspiration, most of this patient might be slightly dehydrated. Third assessment is assessment of lung congestion. There is a valuable tool that mostly overlooked, which is lung ultrasound. It is simple maneuver when knowing that the lung tissue is full of air, and the air is a bad conductor of ultrasound wave. So in this case, with normal lung, you will get this black jet of a healthy lung, and the only thing here is a transverse line caused by reflection of ultrasound and some artifact behind it caused by reflection of ultrasound on the pleura, and this is normal, called A lines. On the other hand, if the lung become filled with fluid can reflect ultrasound and what is called lung comets or B lines, which is a vertical lines moving with respiration along the view. How to get this picture? Simply, we have there is multiple algorithms for or protocols for lung ultrasound. The simplest one is the 8-point protocol, 4 in each lung field, in front and on the axilla, at this 4 points on each side, with the probe facing at the 12 o'clock facing upward, and adjusting the depth of the picture, you will get this picture on the healthy lung and this picture in the congested patient. What is the cutoff point for B lines to assume this lung is congested? The required cutoff point is 3 or more B lines in each view, seen in at least 2 or more sides of these sites. Second scenario is septic shock. Simply, if we go through the previous views and get a good LV function, but finding the inferior vena cava below 1.5 and fully collapsing, this means this patient is slightly hypovolemic or might have element of distributive shock like septic shock. We can get some clues about the stroke volume and cardiac output from simple measurement of the echo, although it is not 100% accurate as invasive parameters, but it might give a clue. Simply, from physics, if you have the velocity of flowing fluid, and you have the diameter or the area of the structures that this fluid go through, you can get the volume of this fluid. So in case of heart, if we have the diameter of the left ventricular outflow tract, which measured just below the aortic valve at the parasternal long axis view, and you have the velocity of the blood at the left ventricular outflow tract, which measured by putting the pulsed wave Doppler at this point in the apical 5-chamber view and tracing the flow, which is called velocity time integral. We will not go through this, but if you get this post measurement, you will get automatically the stroke volume. And as we all know, if we multiply the stroke volume by the heart rate, you will get the cardiac output. Also, another implication of this measurement is if you have a patient and you don't know this patient is dehydrated, or this shock might respond to fluid or not, even in a cardiogenic shock patient, by measuring the fluid or the response of fluid in this patient, by measuring the stroke volume change by just passive leg raising of the patient. If you find by passive leg raising of the patient, which causes some auto transfusion of the blood of the patient, you find that the stroke volume increased by 15%. That means that this patient mostly will be fluid responsive if you give him some fluid. This is one of the clinical implications of these calculations. Third scenario is obstructive shock that might cause pulmonary embolism, and as we discussed before, just spotting the probe at the apex and getting the apical 4-chamber view, finding this image with RV almost double the left ventricle, which means RV dilatation. This is one of the sign. Picking another sign, which is akinetic or dyskinetic RV free wall with only moving RV apex, Myocardial sign, and a third clue, which is 66 sign from tracing the RV systolic pressure from continuous wave Doppler over the tricuspid valve at apical 4-chamber view, and tracing the pulmonary acceleration time at the short axis great vessel view using continuous wave Doppler. If you get both reading below 60, we have 66 sign, a third sign that might help you in the diagnosis of such. The final scenario is cardiac tamponade. Actually, cardiac tamponade, we might have a false idea that if we have more fluid, you more likely have tamponade. Actually, it is a matter of the rate of accumulation of this volume rather than the volume itself. Because commonly at cath lab practice, if you have some perforation in one of the coronary artery during PCI procedure, even a few millimeters of fluid accumulating rapidly at the pericardium might cause cardiac tamponade. On the other hand, if the patient have progressive pericardial effusion, even massive effusion but accumulated gradually over months and days, the pericardium compliance get adapted with this, so the pressure rise more slowly. Here is the first scenario: a patient in cath lab get perforation or something like that with rapid accumulation of fluid. Even a few fluid might cause rapid rise of the pressure inside the pericardium and causing tamponade. On the other hand, it take more time, more fluid amount to accumulate over time, reaching the same threshold to get tamponade in chronic patients. So how to assess cardiac tamponade? First, as we said before, we measure the effusion. This might be helpful in deciding is it feasible to get through it through percutaneous method, subcostal drainage. The cutoff point is 1 centimeter or more fluid related to the right ventricle at end diastole, as we said, because if we measured it at systole, we might get slight more false reassuring reading, and when we get a needle inside this effusion, we get into the right ventricle instead of the effusion. So we measure the effusion as we stressed before at the end test. Signs of tamponading, simply when we get this view, the apical portion preview, and while the valve is open, which means at the diastole, we saw this picture of the right ventricle become compressed during diastole. This is one of the echo signs of tamponade. The second sign is a reflection of pathophysiological issue of pericardial tamponade, where the phenomena of ventricular interdependence become exaggerated, which means when the patient takes inspiration, the right-sided venous return increased, while this couldn't happen on the left ventricle, where the pulmonary venous drainage is limited by the raised intra-pericardial pressure. This caused septum to become slightly shifted towards the left ventricle, causing decreased flow over the left ventricular outflow tract and mitral inflow, while this variation become on the opposite side increased on the right side. So how to get this signs clinically? Clinically by measurement of what is called pulsus paradoxus. But what we can do with echo, just putting the cursor at the mitral valve opening pulsed wave Doppler button, we get this waves of mitral inflow with blood flowing from left atrium towards left ventricle. If we get a variation with respiration of flow caused by the exaggerated ventricular interdependence that we discussed, the cutoff point of variation more than 25%, this is one of the signs of tamponade. Similarly, if we put the cursor at the tricuspid, the cutoff point here is slightly higher, 40%. If we get 40% variation with respiration, this is another sign of tamponade. And this sign without any measurement, which is swinging heart is moving in every direction, itself is an echo sign of tamponade. So another method to assess the RV free wall collapse during diastole is putting a cut section at the parasternal and long axis view at the level of the mid ventricle, at the level of the mitral valve leaflet, and mitral valve open at diastole. So during mitral valve opening, if you go through and look at the RV free wall and get this indentation or collapse, this means that there is diastolic collapse of the RV free wall. And here is the variation with respiration at the mitral inflow using a pulsed Doppler. If we measure the largest waves and the smallest wave and to find the difference more than 25%. This means this echo sign of tamponade. And similar exercise at the tricuspid valve tip, but with a different cutoff point, 40%. This is also a sign. So back to the original slide of the different scenario. If we go through the different view and get depressed LV function with congested or dilated inferior vena cava and congested lung, this might give clue about cardiogenic shock. If we get good LV function but with empty inferior vena cava or collapsed fully with respiration, might go with distributive or hypovolemic shock. If we found dilated RV with markedly elevated pressure but below 60 or Myocardial signs, this go with obstructive caused like pulmonary embolism. And if we just put the probe and found RV diastolic collapse, this might give a clue about tamponade. So memorize this view. The probe at the third space directed to the right shoulder, gets the external long axis, rotating clockwise towards the left shoulder, getting the short axis view. Then at the apex, getting the apical four-chamber view. Then at the subcostal site, directed toward the third 3 o'clock to get the subcostal view, or at 12 o'clock to get the inferior vena cava view. And then by picking information from each one of these view about the LV function and regional motion abnormalities, RV dilatation and elevated pulmonary pressure, presence or absence of pericardial effusion, presence of aortic flap, IVC diameter, we might get a clue in the clinical scenarios that we have discussed. Finally, you might find at this link this valuable book of European Association of Cardiovascular Imaging. It is a good start for echo practice. And this website have a simulator of the different views of echocardiography to get more familiar of different views. And thank you.